For those of you who have already joined, we're waiting about, I'd say 1-2 more minutes before we're going to get started, to give others time to join. I think we have a quorum. I suspect there'll be others joining in the next couple of minutes, but why don't we start? It's my pleasure to introduce Dr. Sarkar today. She is a faculty member in the Division of Endocrinology and Metabolism here at Johns Hopkins. Her office is specifically at Bayview. She got her MD and did a residency at Yale and got her fellowship in endocrinology at Vanderbilt before coming here to Johns Hopkins in 2017. And I think it's we're in for a treat today in regard to her presentation. So please go right ahead.
Thanks, Dr. Moore. Hi, everyone. Thanks for the invitation to come speak with this group. I always enjoy attending these meetings. I'm hoping today's talk can be a little informal, so please feel free to ask questions during the course of the talk or to use. I don't know that I can see the chat, but if you'd like to ask a question, please feel free to. So my talk is titled Current Concepts in Cardiometabolic Diseases in People with HIV. As Dr. Moore mentioned, I'm an endocrinologist, and in my clinic focuses on diabetes, obesity, and cardiovascular risk reduction. So let me just advance my slides. I don't have any disclosures. So the objectives of today's talk are to understand the scope of cardiometabolic diseases among people with HIV, review the mechanisms by which cardiovascular and metabolic diseases, review the mechanisms for the increased risk of these diseases among people with HIV, and to look at approaches for monitoring risk and treatment for cardiometabolic disease in people with HIV. So I'll start with the first to kind of review the scope of this issue. So this is nothing new to, of course, this audience, but we know that people with HIV are living longer, which is great. So mortality is decreasing, and this graph shows that from 2010 to 2018, total deaths among people with HIV has been declining, which is wonderful. That being said, people with HIV are increasingly becoming an older and aging population. So in 2018, about half of people with HIV in the US were 50 years of age and older, but by 2030, that's projected to be almost 3/4 of people with HIV. So what we're seeing now is that people with HIV are more and more experiencing diseases of aging. And these, of course, include diseases that we treat in our clinic, which are overweight state, obesity, diabetes, non-alcoholic fatty liver disease, and cardiovascular disease. I think this is in sharp contrast to the early HIV epidemic, in which HIV-associated wasting was seen in people before the arrival of ART. It was a negative prognostic indicator, and basically it was a condition in which there were increased energy requirements, patients had less appetite, and in people with advanced disease, there was decreased intake of nutrients and absorption, but we of course do not see this as much. In the early days of the HIV epidemic too, there was a return to health phenomenon in which once antiretroviral treatment was started, there was a decrease in catabolic effects of HIV and people gained weight. And this was considered a good prognostic indicator to showing reduced metabolic demand. But in the present day, what we're finding is that overweight and obese states are increasingly prevalent among people with HIV. And that's shown nicely in this graph. This is from a study by John Bertos at Vanderbilt. And on the left, you have the two graphs on the far left are showing overweight, obese rates among people with HIV, males and females. And you can see that from 1998 to closer to the present day that the rates of overweight and obese states have been increasing. And that reflects what we're seeing in the general population as a whole. So on the right are graphs looking at overweight and obese states, so BMI from 1998 to closer to the present day, and we can see that BMI has also been increasing in the general population. So what does that mean? So people with HIV are increasingly overweight and obese. Does that have an impact on disease outcomes? And the answer is yes, it actually might be different among people with HIV versus people without HIV. So what these two graphs show, this is from the VA, and on the far left are veterans without HIV, and on the far right are veterans with HIV. And this is looking at incidence of diabetes with weight gain. So on the y-axis is incidence of diabetes, people who are getting diabetes, and then on the x-axis is the change in weight. In people with HIV, it's starting from ART initiation, and then the people without HIV, these are matched by age, sex, and race. These were the first earliest BMI value that could be found. And what the graph is really showing on the far right is that for a given increase in weight, the risk of diabetes is higher among people with HIV than in people who are uninfected. So the take-home point of this graph is that for a given weight gain, it seems that people with HIV have a greater risk of developing diabetes than people without HIV. I think the question of whether prevalence of diabetes is greater in people with HIV than people without HIV, that's been studied extensively, and there's some data to suggest that yes, the prevalence of diabetes is greater among people with HIV than people without. This is looking at data from two different cohorts. One is the MMP, looking at people with HIV, and the other is from NHANES. And in red, I've circled the prevalence estimates of diabetes among two different cohorts. So one of people with HIV, the other general population, and you can see the prevalence estimate for diabetes among people with HIV is greater at close to 12% compared to the NHANES, which is a general population cohort. So that's the diabetes part. What about other metabolic diseases? And one that I know that you all as HIV providers see very commonly in your clinic are patients with fatty liver disease. So NAFLD, or non-alcoholic fatty liver disease, is really a spectrum of diseases ranging from just simple steatosis, 5% steatosis in the liver, all the way to cirrhosis. And it's a progressive kind of continuum where there can be just simple steatosis to inflammation, as is seen in NASH. And this is highly prevalent among people with HIV. The prevalence estimates really vary. It ranges anywhere from 31 to 73%, and in parts because of differences in detection that have been used in different studies. But certainly people with HIV may have other risk factors for NAFLD, including HCV co-infection. And we know that NAFLD increases the risk of cardiovascular disease. So this is another risk factor that many people with HIV have that increases risk of heart disease. In kind of segueing to heart disease, what is the risk of heart disease among people with HIV? We know it's increased, and that's shown in this plot here. So in the top, you have studies that look at the risk of MI in people with hypertension, diabetes, lipid, and smoking. And then at the bottom, you see how HIV infection is confers risk of heart disease events in comparison to these traditional risk factors. And what this basically shows is that HIV is as strong a risk factor as some of the traditional risk factors we think of, like hypertension and diabetes, for developing cardiovascular disease. Okay, so I wanted to talk a bit about the mechanisms that increase risk of cardiometabolic diseases in people with HIV. These are generally divided into traditional risk factors, so increased weight, hypertension, diabetes, hyperlipidemia, but there are also non-traditional risk factors that are unique to people with HIV, and these can include antiretroviral therapy, as well as chronic inflammation. I wanted to just touch base on some older studies, kind of landmark studies that looked at unique risk factors for metabolic diseases among people with HIV. And this is a study that was published many years ago in 2005 that looked at the prevalence and incidence of diabetes among people with HIV. So this was published by Todd Brown in 2005 in Archives of Internal Medicine. So this looked specifically at the multicenter AIDS cohort study, or the MAX. And I know many of you know this, but just as a review, the MAX, it's an ongoing prospective cohort study for men with or at risk for HIV at 4 sites. And all the men who are part of the study undergo semi-annual visits for a history, physical examination, and specimen collection. So in this study, the question was, what's the prevalence and incidence of diabetes among men with and without HIV? And so in this table, this is unadjusted values, but this looked at the prevalence rate of diabetes among the men in the MAX, and you can see that the prevalence of diabetes among men with HIV on ART was much higher than people not on ART, and then compared to uninfected men. In this graph, this shows on the y-axis patients free of diabetes on the y-axis, and then this is time in the study, so this is over time, up to 3 years. In the dashed line were men with HIV on ART, and then in the solid line are men without HIV. And you can see that more of the men without HIV were diabetes free than men who had HIV who were on antiretroviral therapy. I think one thing to know that in this study, this is an older study, most of the men with HIV on antiretroviral therapy were on a protease inhibitor. Many of these were on ritonavir, and several of these people were on were receiving another PI as well. So it's unclear from the study, which is a smaller study, if this effect was from a combination of protease inhibitors. One thing to note, among the earlier generation protease inhibitors, indinavir has been shown in vitro studies to hinder the glucose transporter, the GLUT4 glucose transporter. Okay, so switching gears a bit to more current data, this is looking at weight change and absolute weight in people on different types of antiretrovirals. So in red are patients who are on integrase inhibitors, blue protease inhibitors, and then in green NNRTIs. And this is a pooled analysis of 8 randomized controlled trials looking at treatment-naive people with HIV who are starting antiretrovirals between 2013 and 2015. And you can see how over time, after starting treatment, that patients, there was an increase in weight change and also an increase in absolute weight. And this is really marked among people on integrase inhibitor. This is from a study that was published by Jordan Lake that looked at what happens to weight when when patients are switched from non-integrase inhibitor therapy to integrase inhibitor therapy. In this study, this looked at over 600 people who were people with HIV with viral suppression at the time of switch. And so in this graph, you can see this is kind of the whole duration of follow-up. And on the far right, this is kind of limiting this window to the 2 years before switch and 2 years after switch. And you can see that really weight gain kind of takes off after switch from non-integrase inhibitor to integrase inhibitor therapy. And that's a question that I think is still being discussed among experts of why is this weight gain seen when there's a switch from non-integrase inhibitor therapy to integrase inhibitor therapy. One of the hypotheses is maybe they're just better tolerated, less side effects. People are able to gain weight as a result. There has been some preclinical work that's been done to see what's the effect of integrase inhibitors on adipose tissue. And then there's some data to suggest that it actually suppresses brown fat function and increases white adipocyte differentiation, and that there may be this may be through the estrogen action inhibition. So that's integrase inhibitors. What about other antiretroviral therapies? So again, this is not something that this audience doesn't know, but this question of TAF and TDF. So TDF, we know the disadvantages are increase in bone mineral density loss and then the adverse renal effects, whereas TAF is newer and there's less of these toxicities. But what about the change in weight? So here is this is a large study that was done of almost 7,000 patients. And this is looking at switch from TDF to TAF. And you can see here, I'm going to zoom in on it. You can see there's a weight gain acceleration in the first 9 months after switch, to almost 2.4 kilograms per year during this period of time. So one hypothesis for this is that this increase in weight may be because TDF is kind of weight suppressing. So maybe switching to TAF reduces the weight suppressing effect. So I think what I've been trying to show in these slides so far is really that we know ART can be a risk factor for metabolic disease. But what about inflammation? So that's kind of the flip side of this. What I'm trying to show in this graph, this is from the MAX study. So this is looking at various cytokines and pro-inflammatory markers. So they're listed at the bottom of the graph here. And this is comparing people with HIV not on treatment to people without HIV. And you can see that generally markers of systemic inflammation are greater among people not on treatment to people who are uninfected. In the filled circles, you can see that some of the circles are filled in. These are statistically significant. And this is adjusting for covariates such as age, race, smoking, obesity, and diabetes. And I know this is familiar to many of you, but that antiretroviral therapy doesn't fully suppress suppression in people with HIV. And you can see that here. So here in the red, these are people with viral suppression compared to people who are uninfected. And you can see that despite viral suppression, that many markers of inflammation are still elevated despite adequate treatment. And I think the other thing I wanted to note is that with antiretroviral therapy, the most of the improvement in systemic inflammation is seen in the first year, and that's shown in orange is the change in inflammatory markers after the first year of treatment. But that after the first year, there's really not much change in inflammatory markers after the first year of treatment among people with HIV. All of this to say that inflammation, as we know, is really associated with serious non-AIDS illnesses and death. And that's shown here nicely in the graph on the far left. So these are kind of cumulative scores of IL-6 and D-dimer. And in red, here's the highest quartile of inflammation. And this is showing that there's greater events, meaning serious non-AIDS illnesses and death among people with the greatest amount of inflammation. So the question is, how is systemic inflammation related to these cardiometabolic diseases like diabetes, heart disease, and NAFLD? It's been looked at, so inflammation is thought to be associated with incident diabetes in people with HIV. This is a study also that was done by Dr. Brown that looked at inflammatory markers among people with HIV 48 weeks rather after antiretroviral therapy initiation, and whether or not that was associated with incident diabetes. And what this study found was that at 48 weeks, those people with the highest levels of soluble TNFR 1 and 2 had a greater risk of incident diabetes. So this basically shows that there's some relationship between some inflammatory markers and incident diabetes among people with HIV. What about heart disease? So this has also been studied among people with HIV. a couple of different ways. So one is looking at actual function, subclinical function of coronary arteries. So this can be done using a non-invasive method of MRI. And what this does is that patients do a isometric hand grip exercise, and in people with normal coronary arteries, there should be an increase in area of the coronary artery, as well as an increase in velocity and flow of blood through the coronary arteries. And you can see that here. So healthy is denoted here with the white columns. And so there's an increase in area, velocity, and flow with an isometric hand grip exercise in people with healthy coronary arteries. Whereas in people with coronary artery disease, you see there's not an improvement in area. There's no increase in area, no increase in velocity or in flow. So this type of dynamic imaging study has been used to measure coronary function in people with HIV. This is from a study by Dr. Alison Hayes. And so she showed this really nicely in the study where she looked at people with and without HIV, with and without known coronary artery disease. And so on the left, you can see here that there's an area change in the coronary artery from baseline with an isometric hand grip exercise. And in gray here are people who are uninfected without coronary artery disease. But what's really interesting is that you can see that people without coronary artery disease but who have HIV, there's a significant drop in the area change with the isometric hand grip exercise. So the coronary arteries are not functioning correctly in people with HIV, even though they don't have known coronary artery disease. And you can see here in blue are people who are uninfected with known coronary artery disease. And then here are people with HIV who have coronary artery disease. So this is really, I think this is very compelling to see the difference between people with and without HIV who don't have coronary artery disease, but you can see there's a drop in function. So there's no improvement in area change from baseline, and same with blood flow through the coronary artery. What Dr. Hayes also showed is that IL-6 was inversely related to coronary functions. And what she showed here in the study was that IL-6 was greater among people with HIV who did not have heart disease than people without HIV who did have heart disease. What about not just coronary function, but inflammation and structural cardiovascular disease? So this has also been looked at in the MAX study by Dr. Post. So Dr. Post has a cardiovascular sub-study within the MAX. In this study, participants in the MAX have undergone a cardiac CT, as well as coronary CT angiography. So I'm going to talk a little bit about that. So coronary CT angiography is a really helpful tool when it comes to looking at subclinical heart disease because it detects not only presence of coronary plaque, but can show plaque composition and the type of plaque, so calcified versus non-calcified. And it also can give a sense of stenosis of the coronary artery. So that is really nicely illustrated here. So on the left, you can see calcified areas of plaque within the LAD, but on the right, this is using CT angiography. It's really hard to see here, but there's kind of a dent here, which is showing some non-flow limiting atherosclerosis that's being picked up by CT angiography. So it's a really nice imaging modality to look for subclinical heart disease in people. So this was used in the MAX, and what Dr. Post and colleagues found was that in men with HIV compared to men without HIV, men with HIV are more likely to have coronary plaque, more likely to have a greater extent of plaque, more likely to have non-calcified plaque, which is more unstable than calcified plaque, and also more likely to have coronary stenosis. So how is that related to inflammation? Well, this graph really nicely illustrates the relationship between inflammation and coronary artery stenosis. And in this study, that meant 50% or greater stenosis of the coronary artery. And this is basically showing kind of a dose-dependent relationship between inflammation and coronary artery stenosis. And this is looking at two different inflammatory markers, IL-6 and TNF-alpha receptor 2. Okay, and then finally, I wanted to talk a little bit about systemic inflammation and fatty liver disease. This has been studied in people with HIV, and some of the mechanisms are thought to be, as follows: that people with HIV have greater levels of IL-1, TNF-alpha, and then also greater levels of transforming growth factor beta-1. And this is something that's secreted by hepatocytes during liver injury, inflammation, and these all contribute to greater levels of liver fibrosis among people with HIV. Another area of interest has been the gut microbiome in people with HIV and how that might also contribute to inflammation and fatty liver disease in people with HIV. And so the mechanisms for this are thought to be that HIV infection disrupts the intestinal mucosal barrier, specifically because HIV replicates in the gut-associated lymph node tissue. And then with this kind of gut barrier disruption, what's seen are changes in the gut microbiome. There's also increased permeability of the mucosal barrier, and this leads to increased translocation of microbial products into the venous portal system. This increases inflammation, and this also contributes to non-alcoholic fatty liver disease. And this is really nicely shown in this graph, which looks at different risk factors for fatty liver disease in people with HIV. One that I wanted to point out as a segue is visceral adiposity. So what's the relationship between adipose tissue and HIV? We know that in some older generation antiretroviral therapy, there's been association with decrease in subcutaneous adipose tissue and an increase in visceral adipose tissue, as well as a legacy effect that's been described in which some of these changes are not reversible. But with less metabolically toxic antiretroviral therapy, we're not seeing as much fat redistribution as was previously seen. That being said, central adiposity is still very prevalent in people with HIV, and one thing to note is integrase inhibitors have been shown not only to increase adiposity in central depots, but also subcutaneous depots. So some people have asked, well, what's the difference between HIV among people who have obesity and who have HIV versus just people who have obesity without HIV? And this isn't an area of active investigation, but I just wanted to show a schematic of what happens to adipose tissue in the setting of obesity. So what happens to adipose tissue is that there's hypertrophy of adipose tissue in people with obesity. There's hyperplasia, and these ovals are supposed to be adipocytes. There's infiltration of immune cells, specifically CD8 T cells, more CD8 T cells than CD4 T cells, and there's infiltration of macrophages into the adipose tissue. So this is all seen in obesity, which is kind of a chronic inflammatory state. And so as a result, within the adipose tissue, we see greater levels of inflammatory cytokines. This contributes to insulin resistance in the adipose tissue and a decrease in insulin signaling. So what about in people who have HIV who are also obese? We see the same same changes to the adipose tissue, but there are additional things. There are HIV-associated proteins and antiretroviral therapies who all have effect on the adipose tissue. As a result, we see a decrease in insulin signaling and a decreased expression of lipid storage diseases. So this really impairs normal energy storage. It leads to excess circulating fats. And then just accumulation of these circulating lipids in compartments like the visceral adipose tissue. Okay, just a few words about monitoring cardiometabolic diseases and risk in people with HIV, and I hope this is a little bit more clinically relevant. But as we all know, A1C is not the best indicator of glycemia in people with HIV, and this was shown in early studies. This was published in Diabetes Care in 2009. This is a prospective study of 100 people with HIV with type 2 diabetes or hyperglycemia. And there was also people without HIV who were age and race and sex matched to these patients. And what was looked at was non-fasting glucose, fasting glucose, and also fructosamine, HIV viral load, albumin, and CD4 count. What the takeaway message of this study is that you can see between people with HIV on the left and the control group on the right that the A1C value, average A1C value, is lower in people with HIV compared to control group, 6.7 to 8.1, but that you could see that average serum glucose was higher among people with HIV than in control groups. This is kind of surprising because glucose levels are higher in people with HIV than would be expected based on the A1C levels that we're seeing here. And this is kind of reflected in current guidelines. So for guidelines of care of people with HIV, what's recommended is not A1C, but random or fasting glucose at the time of entry of care, at the time of starting antiretroviral therapy, and then every 12 months or as clinically indicated in people with HIV. So A1C is not recommended. And that's also reflected in the American Diabetes Association guidelines because of this finding that there's an altered relationship between A1C and glucose in people with HIV. What about cardiovascular risk calculators in people with HIV? Are they accurate? I think there's ample evidence to show that these risk calculators are unless they're tailored, unless they're specific to people with HIV, are generally not accurate to risk of heart disease in people with HIV. And that's shown here. This is a study that was published a few years ago looking at the pooled cohort equation. And you can see that here's the lighter columns are the predicted risk based on that equation. In the darker columns is the observed risk. And there's really a discrepancy between what the risk is for heart disease that's calculated by the general population calculator, which is the 10-year pooled cohort equation calculator, versus what's actually seen in people with HIV. So the observed risk is much greater than what's predicted based on the general population CVD calculator. And that's also reflected in current guidelines from the American Heart Association. This is the primary prevention of cardiovascular disease guidelines for the general population. But what's really important here is that they point out that there are certain heart disease risk enhancers, and among these is HIV infection. So that's acknowledged in these guidelines. But what I wanted to also point out, I think I've circled here, is that among people with intermediate risk of ASCVD, so there's people with a 10-year risk of 7.5% to less than 20%, what this general population guideline recommends is potentially using coronary artery calcium in selected adults to help make that decision of whether or not to start a statin or not. So I wanted to talk a little bit about coronary artery calcium. So this is a non-invasive measure of coronary atherosclerosis, and it gives a score, which is the Agatston score. It uses non-contrast coronary CT to measure, and the score can be anywhere from 0 to greater than 1,000. So it's a pretty good predictor of heart disease in the general population. So for example, in the general population, having this CAC score of 0, it's actually associated with lower risk of future events, pretty low risk. So it's a very good negative risk marker for people in the general population for heart disease. And then, compared to a CAC of 0, anyone with detectable coronary artery calcium, there's an increase in risk of cardiovascular events. So, 1 to 10, there's maybe a 2-fold risk. Greater than 100 or equal to 100, there's a 10-fold increased risk in cardiovascular events. But, is this imaging modality useful in people with HIV? I mentioned earlier that, coronary calcium is highly prevalent in people with HIV. So we were interested in looking at whether or not a CAC of 0, having no coronary artery calcium, was associated with coronary stenosis as measured in people with HIV. So we used Dr. Post's cardiovascular sub-study here. We looked at men in the MAX who had a coronary artery calcium score of 0 at baseline. So 160 of these participants were men with HIV, and 112 were men without HIV. And what we did also is we looked at whether or not patients had coronary stenosis at a future time point. So we looked at baseline coronary artery calcium, and if the patient had a coronary artery calcium score of 0, they were included. And then we looked at whether or not coronary stenosis was present at a future time period. And what we found was that even among men with HIV, there was some risk of having coronary stenosis on imaging at a future time point, whereas among men with HIV, without HIV, who didn't have coronary artery calcium, they were not likely to have coronary stenosis in the future. This is a pretty small study, so I think it's hard to pull much from it, but I think what was interesting is that despite having this negative risk factor, having the coronary calcium of 0, for people with HIV, there was still a risk of having coronary stenosis on imaging several years later. I'm going to touch base a little bit about future directions. So I think one area of improvement in our care of people with HIV is we have to probably better understand how we can prevent heart disease in people with HIV. So that's something that's being currently studied in the REPRIEVE trial. So this is the largest long-term randomized controlled trial to study statin therapy as a primary cardiovascular disease prevention strategy in people with HIV. So this is kind of just a graph showing how the REPRIEVE is structured. So this is it's recruited people who are asymptomatic with HIV on antiretroviral therapy with an ASCVD 10-year risk score of 15% or less. And then patients are being randomized to either pitavastatin 4 milligrams a day or placebo. And the primary endpoint is major adverse cardiovascular events. This includes cardiovascular death, MI, angina, unstable angina, stroke, and PAD. This is ongoing. So this will be really interesting when the results come out. I think another area of interest is targeting inflammation to help reduce ASCVD, not only in people with HIV, but also in the general population. So this was studied in the CANTO study. So the CANTO study looked at preventing recurrent ASCVD in adults with elevated inflammation. So this is a general population study looking at people with high levels of CRP in the recurrence of ASCVD. And these patients were randomized to canakinumab versus placebo. And canakinumab is an IL-1 beta inhibitor. So in this study, what's shown here is here's the placebo arm, and then these are the treatment arms at higher and higher levels. And this is just showing the percent change in CRP from the start of the study to the end of the study. So there's a reduction in CRP when in patients on treatment. But in what was found is that this anti-inflammatory therapy also reduced the risk of ASCVD events in the general population, which is exciting. The only thing is that the company that sponsored this trial did not seek approval by the FDA. So it's not an FDA-approved drug for preventing recurrent ASCVD. That being said, it's still of interest potentially for use in people with HIV. This is a graph that comes from a small study of 10 patients with HIV on antiretroviral therapy who had either established cardiovascular disease or at least one cardiovascular risk factor. And this looked at patients who received one dose of canakinumab, and they underwent FDG PET at baseline and then after treatment. This was 8 weeks after treatment. And what this showed was that not only was there a decrease in inflammation, there was also a 10% decrease in arterial inflammation. So this is really interesting. And there are larger studies. There's a larger study in which canakinumab is being looked at in terms of vascular inflammation in people with HIV. What about other treatments? So semaglutide is a really exciting medication that we use in people with diabetes and overweight and obesity, but it's also of interest in people with HIV. We have a study that we're doing as part of the ACTG here at Hopkins, in which semaglutide is being looked at with its association with hepatic fat. This is really interesting because it's already been shown to help be associated with resolution of NASH in the general population. So we're looking at it in people with HIV currently. So the current study that we have is looking at 24 weeks of semaglutide, and the outcome is change in intrahepatic triglyceride content. So this study is ongoing currently. So I think the take-home points for my study, or for this talk, are really that cardiometabolic diseases are very prevalent in people with HIV, as we all know. People with HIV really do have unique risk factors for developing cardiometabolic diseases, which I've discussed. Methods to evaluate cardiometabolic disease in the general population may not be applicable to people with HIV, and so this means the use of glucose, fasting glucose versus A1C, or even really thinking about using the pool cohort equation in people with HIV and knowing that it may be an underestimate in people with HIV. And I think that there's a lot of promising research going on now with medications such as semaglutide to look at how we can better improve cardiometabolic disease outcomes in people with HIV. So with that, I'd love to take any questions.
Thank you very much. Really appreciate your presentation. Does anyone have any questions? I've been looking at the chat. I didn't see anything there. Let me start. Yeah, David, do you have a question?
Yeah, sorry, my screen is funny. Yeah, I guess just from a practical standpoint, until we have more data, is when you think about some of these conditions like a borderline A1C, would that push you more towards treatment in someone with HIV as compared to someone not? And those kind of borderline ASCVD risk factors, just kind of, though you can't put it in the calculator, just, well, if it's borderline, I'm going to just kind of assume it bumps things up. And until we have more data, is that how you would kind of practice?
I think so, David. Yeah, I think it's a great question. Yeah, I think so, because we know these patients are at higher risk of heart disease, and so I think, for that patient who appears to have A1C of 7, but glucose levels are higher than what the A1C of 7 would suggest, and they have hypertension, hyperlipidemia, and HIV. I think definitely being aggressive about treating cardiovascular risk factors and maybe considering use of GLP-1 receptor agonist, I think is indicated, even though there's no studies that I'm aware of looking at GLP-1 receptor agonists and ASCVD in people with HIV. But I think treating aggressively is really indicated.
There's certainly data on weight gain and even development of diabetes with the INSTIs. Has anyone done, or do you know if anyone's looking at a study whether there's an increased risk of cardiovascular disease? That may be too long-term an outcome, but
yeah, that's a great question. I'm not aware of one, but that's a really nice question. I showed that data with the CT angiogram in coronary artery calcium. I think those are nice because with cardiovascular events, it just requires so many people to be observed. Whereas these, like using CT angiogram is nice because we can structurally see heart disease, even though it may not be clinically evident. So that I think that those have been useful. But yeah, that's a great question. I'm not aware of any link between INSTIs and ASCVD events.
Along the same line, can you talk about INSTIs and diabetes?
Yeah, that's a great question. I think that's something that's still being looked at. We know INSTIs, there's the potential relationship between INSTIs and weight gain, but as far as I know, I haven't seen a clear relationship between diabetes incidence and integrase inhibitor use. It's a good question.
There was a risk calculator that I think that one of the European groups, the ART-CC group, created some years back that tried to add in HIV as one of the risk factors. I don't know if you have any thoughts about that, or you've already commented that the risk calculators don't work as well in HIV. I don't know how that one compared, or whether you've seen any others which have tried to add in HIV infection.
Yeah, I know that there have been some that are developed for people with HIV. I don't know how generalizable they are, but I think you're exactly right. There are calculators that are tailored specifically to people with HIV. I think I don't know how widely they're used in clinical practice. The way the pool cohort equation calculator, is really easy to calculate. Even Epic, I'm able to kind of pull up a smart phrase and it calculates the pool cohort equation. I'm not sure how often these HIV specific cardiovascular risk calculators are being used in practice.
Yeah, I don't either. I know this was pretty early on that they did this, and I think at the time it seemed, at least they have a large cohort in Europe, it seemed to predict better than the the standard cardiovascular disease formula, and but I haven't seen anything from them since, or from anyone else for that matter. So I was just curious. One of the things, and Joyce, if you're on, I chatted with Joyce while you were talking. I know, given that it's really glucose that we need to be monitoring, one of the things we do monitor, however, is A1C, because as part of the clinics showing that they're doing a good job with managing diabetes. A1C is something we're going to have to do. I don't know if you have any comment on that, Joyce.
Yeah, thanks so much, Sudi, for the terrific talk. And like, it's just so nice to be here and have, other specialists who have a special interest in HIV. So we really appreciate, your expertise and a terrific presentation. We now do have point of care hemoglobin A1C in the clinic, and we have Sheila put in place. It's a NEPO. So basically, when patients are due, who have diabetes, who are due for hemoglobin A1C, that is done automatically by the CMAs. And we're part of the MD-PCP program, and that's a metric that we're monitored on. We're monitored on the percent of our diabetes patients who have had an up-to-date hemoglobin A1C completed, and then the percent of our patients who have diabetes who are controlled. And with the advent of engaging in MD-PCP, having that NEPO in place, where our performance has been improving significantly. For providers, we do have a dashboard as well, where we have diabetes metrics on it. So we have, do they have a recent A1C? Recent A1C, it's the threshold is greater than 9, which is like really poorly controlled. But I think I chose that because that's part of the ambulatory dashboard, but you could at least see who's like really out of control of your patients, and then do these specific interventions. I'm sorry, Sudi, I was in and out of the talk. Yeah. Did you mention the diabetes self-management training program?
No, and I'm sorry I didn't, but I'd like to bring that up. Thanks for bringing that up, Joyce. So the diabetes self-management training program is a referral that can be placed in Epic, and you just type in DSMT, and that really should be placed for any patient with diabetes, and it provides up to 10 hours of education in the first year, not of diagnosis, but of the first year of education, and then up to 2 hours every subsequent year. And it's really great. It's based on standards of care for people with diabetes, that they be offered this type of education, and it involves meeting with a diabetes educator, and that could be an RN or a dietitian. And then it's really an excellent program. In addition, what's nice is these diabetes educators are able to titrate insulin based on HbO policy. So we have a kind of an algorithm within which these diabetes educators can adjust insulin. So they're really a great resource, and I would really encourage everyone to place this referral for any patient with diabetes. And the visits can be done either virtually or in person, and they have diabetes educators not only at Bayview and at the main campus, but at all of the Hopkins satellite clinics.
And then you also have the prevention. There's also the prevention program as well.
So yeah, exactly.
Pre-diabetes,
pre-diabetes, gestational diabetes, and these patients can be referred to the diabetes prevention program. There is a BMI cutoff, which I can't remember. I think it's 25 that the patients have to meet, so they can't be within a normal BMI. But it's also a great program. It's a 1-year program in which a group of patients meet at a certain time every week with a diabetes educator, and that's been shown to help reduce the progression to diabetes. So please, getting the referrals for these patients. They really greatly benefit from it.
And in Epic, it's really easy to do and it will actually prompt you as well. If you look in the upper left-hand corner of like when you log in for a patient, you'll see kind of yellow things that are some suggestions for interventions for certain patients, and the DSMT, well, definitely the prevention, the pre-diabetes comes up, and it gives you the criteria when you place the order. And then the DSMT is terrific. I've used both a lot. Eugene Arnold, who runs the DSMT, is
fantastic,
amazing. And I've even reached out to him about individual patients who, like I had a patient who had totally lost her insurance. She needed insulin, and he really just helped facilitate everything. So really, really wonderful services. I actually have a question too, if I can hog some time.
Yeah, go ahead, Julie.
So did you talk at all about, sort of the newer medications that promote weight loss and like Ozempic and those? I'm having a lot of difficulty getting approval, both for people who do have diabetes and then people who are obese and have other comorbidities, for which it could be helpful. Did you talk about that at all, or
I didn't mention it too much, but the GLP-1 receptors are such an integral part of our clinic, and we prescribe them a lot. That being said, the coverage can depend on the insurance type. Priority Partners has pretty good coverage for GLP-1 receptor agonists. I think dulaglutide is covered. You all may be aware of, and I wish I'd mentioned this, is tirzepatide, which is Mounjaro. It's a dual GLP-1 GIP agonist. It's made by Lilly, and it's a once-a-week injection. Patients with commercial insurance, it should be covered as low as $25 a month. What I do is, for patients with commercial insurance, even if Mounjaro is not covered, what I ask patients to do is go to the Mounjaro savings card, and I'll actually put that in the chat. It's called the Mounjaro savings card, and they just need to print out the savings card and present it to the pharmacy, it should be covered as low as $25 a month. The patients don't have to print out the coupon card every month. The pharmacy keeps it on file, even if insurance denies it. If insurance denies the medication, the savings card should cover it for commercially insured patients. That being said, it doesn't apply to Medicare, Medicaid patients. But that's a really nice drug that we're using more and more now, especially as you all probably know, Ozempic or semaglutide there's a national shortage. So patients who are on it just can't seem to find it anywhere. For that, what I've asked patients to do is call pharmacies. This is not the greatest thing, but unfortunately we don't have a good option. So call pharmacies around them and see if it's in stock, because it can really vary from one street to the next. Like one pharmacy might carry it, another might not, and it really varies week to week in terms of supply. So that's one option. The other is to switch them to a different GLP-1 receptor agonist, from semaglutide to dulaglutide, which is Trulicity, or if they have commercial insurance, I try to switch them to tirzepatide, which has been shown to be superior to semaglutide in terms of weight reduction and A1C reduction. So I've been converting a lot of people to tirzepatide.
Yeah, if you have any good resources for us along the lines of different agents, and then any insight you have about like approval and stuff like that, that would be super helpful if you have it. And then I want to also give a plug for in the clinic, Kristen Kilcrease sees people for diabetes management as well. So if you have folks who it's difficult for them to engage with endocrinology, in-house, Kristen actually meets with patients and will help manage diabetes treatments as well. So that's another resource within Bartlett.
For patients who are averse to needles, there's a number of patients who have a fear or reluctant to use needles. Semaglutide comes in an oral form, which is Rybelsus, and that comes in 3 different strengths. I don't use it a lot because what I found is that the risk of GI adverse effects is a little bit higher. It has to be taken on an empty stomach 30 minutes before eating or drinking anything. But I think it is certainly an option in people who are averse to using needles and would prefer to use an oral medication. but the same side effects are still there as we see with the injectable GLP-1 receptor agonist. I don't think there's any cardiovascular benefit though with the oral semaglutide. I'm curious to see also what the uptake of SGLT2 inhibitors is among people with HIV in the Bartlett clinic, if that's something that's being prescribed more often by providers.
I'm sorry, what was the question again?
The SGLT2 inhibitor use.
In our clinic.
In the Bartlett clinic, yeah.
Yeah. I don't, maybe love to hear from other providers. The only patients that I have on it actually were patients seen by endocrinology. Are there other folks on here who have used these agents?
I will say there's not a lot of literature looking specifically at SGLT2 inhibitors in people with HIV. I wish there were more, but I think that it would be great to see more uptake of GLP-1 receptor agonists and SGLT2 inhibitors just because of their cardiovascular benefit. These are great drugs. SGLT2 inhibitors, some are also have an FDA indication of reduced diabetic kidney disease. So in HIV, as we know, can be a risk factor for chronic kidney disease. So I think it's a great time to be in diabetes medicine because benefit for patients in our clinic. But I think a lot of these medications as novel agents could be very useful in people with HIV.
Yeah, maybe you could come back and just give a talk about that, honestly, because I think, so much of it is just familiarity, right? And then the insurance, it can be honestly a barrier. So
Joyce, I will say that for patients with Medicaid, I have not been able to successfully get medications approved for weight loss alone, unless they have diabetes. So I have a patient with obesity and pre-diabetes, but I wasn't able to get like the Wegovy, which is semaglutide, that's a brand name for semaglutide for weight loss. I wasn't able to get it approved, so that's really disheartening. But happy to come back and talk about GLP-1 receptor agonists and other agents.
that would be amazing. And Sonia, you've successfully prescribed treatment for someone.
Yeah, I used empagliflozin, but then the person was hospitalized with a bad UTI. So then I took them off of it, but I have used it.
Thank you.
Well, we're at the hour. Are there any other questions? Well, again, I want to thank you for your presentation today. I think it was, I learned a lot, and I'm sure we all did, and I really appreciate your time. And if you can come back and talk to us again in the future about some of these medications, that would be great.
Great. Thank you so much.
All right. Thank you all.
Thank you.